So, welcome to this new ISICEM series of podcasts. Today, we have the pleasure to have Daniel Leisman with us from Boston, United States. Welcome, and thank you for having accepted to participate in this new initiative.
Of course, thank you for having me.
So, you may know him from the numerous amount of papers that is published recently. He's very productive researchers, and the title we have chosen for our conversations today is about angiotensin II and other troublemakers, which is pretty wide. So I will try to give you some questions to pinpoint a little bit what's your clinical practice, what are your advices regarding second-line vasopressors, basically. And the first question I would like to give you comes even before a second line. So it's about your first line strategy. I guess it's going to be norepinephrine. Do you have a maximum dose or regimens or criteria to get particularly alarmed? What is your current practice about it?
It's a really good question. You're correct. When the interns and the residents are asking, what's your framework for your selecting your first line vasopressor, and I usually just tell them you start norepinephrine and don't try to get cute. But I think from there, it's we talk in critical care a lot about how most of the things that we do hurt people. Too much ventilator leads to problems. Too much dialysis, too much critical care leads to adverse outcomes. And I think in 5 to 10 years, we're really going to be talking about catecholamines the same way. And so really, as soon as I start the norepinephrine, if we still see those vasopressor requirements are increasing, I'm already starting to think about what I can do to offset the catecholamine load these patients are getting. So for those, if you're using weight-based dosing, that's somewhere around as early as 0.15 to 0.2 of norepinephrine, I'm already adding other agents.
So that's pretty early. I think we're talking norepinephrine equivalent dose. Maybe you're not accustomed to the fact that here in Europe you use different formulations, sometimes with the tartrate, which has made a little bit of confusions in the literature when reading the papers. Sometimes we do not really understand, and that's have led, I think, people using thresholds that are sometimes double than what they actually thought. Okay, now, you start pretty early. What do you start? How do you select the good treatment for the right patients, actually?
I think a lot of it is a function of, what you have available at your shop. And so for us in the United States, where, cost plays a significant factor, vasopressin is almost always the thing I'm reaching for first, just because it's widely available, it's cheap, and there's not a lot of pushback on that. But I would say once we get back towards that 0.15 to 0.2 of norepinephrine, if I'm already on vasopressin, that's the point that I usually start reaching for angiotensin II.
Okay, so you put vasopressin, and then immediately after, if it's needed, you're already third-line vasopressors with angiotensin II. And you aim for reducing, of course, for the mean arterial pressure thresholds you're selecting for your patients, but how do you see if you reached a goal? Is decatecholaminizations what you're aiming for, or better control, or diversifying through multiple treatments? What is the main goal for you?
Yeah, every patient is different, right? You have to look at the person in front of you. And so you're looking at things like their markers of their perfusion, their lactate, their urine output, and you're seeing, are you getting what you want? But I think in the back of my head is always what dose of vasopressor is required to get the map to where, whatever arbitrary goal we've set for this patient. And so my practice has just become to use as many adjuncts as I possibly can, like I said, to avoid that overdose of catecholamines.
Okay, yeah, sounds logical. At least to me, it sounds very logical. There is a little bit of a problem that I have, that my colleagues also have, with the second-line vasopressors when the cardiac output is low. And those, the idea is that if we just increase the resistance, but without providing some beta stimulations like with norepinephrine, we might end up having more of bad consequences than you could. Is something that hits your mind too, or
this comes up all the time? And this is something that I think is one of the risks of this, that adjunctive early approach and adding things to keep norepinephrine doses low, is that Now that we have this many vasopressors, you can make the map look like what you want for a long time, but you have to go down the diagnostic pathway of making sure you're not missing something else. And vasopressors are a treatment for vasodilatory shock. They are not a treatment for a low output state, and they're not a treatment for low filling pressures, right? Those are totally different physiologies that cannot be managed with the vasopressor alone.
Yeah. So you pass through the case of being sure there is a fairly good cardiac output. I don't know, like thinking about studies on vasopressin, I think that the cardiac index 2.1 was the minimum requirement to get enrolled in these trials. That sounds fair to me, but maybe we should look even higher. I don't know. And what's your take about?
Yeah, I don't think that there's a specific cardiac index number that we're going to look at.
Okay.
I think a lot of it is tailored to the patient in front of you, and I admit I can be a little bit smooth-brained about this, which is, the starting point for a patient in shock for me is, are they fluid responsive or not? And if a patient is very clearly fluid responsive, then I'm going to start with fluid resuscitation. But when I'm at that point with the patient's not fluid responsive, then we're moving on, and then we're assessing filling pressures, whether that's with echocardiography, whether that's with invasive measures, or whatever technique you want to use. But I think that physiologic approach is how you rule these entities out up front.
Okay, and thinking about angiotensin II, there's a lot of profiling that came out from the ATOS-3 trial as mainly sub-studies, trying to suggest one category or another that could benefit the most. Which one are you actually considering as the potential best candidate for angiotensin II?
I think there's three big groups of patients that I think about angiotensin II early in. The first is patients with a severe acute kidney injury or who are on renal replacement therapy. And that's not just out of the ATHOS-3 data. There's been numerous case series at this point. We have cohorts out of the COVID-19 pandemic that showed that angiotensin II in those patients seem to improve both overall and renal outcomes. And that makes physiologic sense with what we know about efferent arteriolar regulation under the RAS system. The second group of patients I think about is patients with ARDS and acute lung injuries. And that is because we've known since the 1990s that inflammatory lung injuries produce shedding of ACE from the pulmonary endothelium. And we saw again in the COVID pandemic that late elevations in RAS markers were strong predictors of subsequent organ failure and respiratory severity. We saw in ATHOS that the patients with ARDS at baseline who got angiotensin II had improved hypoxemia by hour 48. And we saw that in the REMAP CAP trial, the study was stopped early because of a high probability of harm. And that was not just cardiovascular endpoints, that was respiratory endpoints. So that's the second group of patients I think about.
They were starting angiotensin receptor blockers or angiotensin.
So they were randomized to either ARBs or ACE inhibitors. As you know, this is the only trial in COVID that was done in critically ill patients exclusively. And those patients who got an ACE or an ARB had more than 95% probability of increased ventilator days, increased supplemental oxygen days, and respiratory status at day 14.
Okay, and do you have a strategy where you can do it bedside somewhat to see if your patients to see if the patient is responsive or to see will respond, what is the likelihood to respond? Those are still expensive medications, so will be very useful to know if my patients after a while will require a second vial or more.
Absolutely. And that's the hardest thing about this. And I hope if you ask me that question in a few years, I'll be able to say, well, I'll just order a blood renin level, and because that has by far the most robust data supporting it, or some of these other RAS blood markers, metabolites. But I don't have that. If I want to get a blood renin level, I have to send it out to the Mayo Clinic in Rochester, and 5 to 6 days later, I will find out what the renin level was, which is not helpful.
Good for retrospective studies, mostly.
Yeah. So what we've started doing, and what we validated in a couple cohorts now, is this concept of the aim-right index, which is very simple. It's just starting at the point you want to start therapy, measure what the patient's blood pressure is, start angiotensin II at whatever dose you're going to start it at, wait an hour, measure the new blood pressure, and divide that by how much angiotensin II it took to get you there. So just the difference in MAP divided by the angiotensin II dose to produce that MAP. And that gives you a pretty good sense of how hemodynamically responsive that patient is or not. Usually a cutoff of about 0.9 is what we've validated in a couple cohorts now. But like anything, this is a continuous score, right? And so this idea that 0.89 is somehow very
Yeah, of
different than
course.
0.95 is crazy.
But the more you go towards or beyond that, it's probably going to predict that your patient is very responsive and the Ang2 will be the right medication for that patient. If you don't have a renin bedside, which I also don't have. So for
Right.
us, it's a variable time between 1 and 4 days after. So it's useless at present.
Yeah.
Now we've put all these medications. You know that your patient is responsive. How do you win them? Which one will you win first? And how do you have protocols in your unit? Something to suggest to our?
There are some protocols, but I feel like this is where it really becomes art and not science. And the expression we use on rounds a lot of times is what do they like? There's a fair number of patients I'll start vasopressin on, and I feel like it doesn't do anything, right? And so for that patient, we'll just take it off. Similarly with vasopressin and Ang2, there are some patients who have these robust hemodynamic responses, and on those patients, we'll try and come way down on the catecholamines before we start weaning those agents off completely, because it doesn't really make sense to start angiotensin 2, have the patient's norepinephrine requirement go from 0.35 mics per kilo per minute to 0.05, stop the angiotensin 2, and end up right back where you started.
Yeah, makes sense too. Do you use methylene blue or any other vasopressors in your clinical practice? Some people use epinephrine after cardiac surgery. Some others use pure alpha agonists. Probably there's not much place for pure alpha or pure agonism, except in very selected populations. When everything is lost, what are you going to do? And you just ramp up the dosages, or you go through a fourth line, fifth line?
So as you can probably guess from my view of high-dose catecholamines in general, I have a low threshold to reach for these rescue therapies. I've used a fair bit of methylene blue in my practice. I occasionally will use cyanokit as well when it's available. But on the flip side of that, there is no max dose of anything, right? There's just toxicities that you incur. And so if a patient is actively dying and we think there's something reversible and we're trying to really stabilize them through that, we'll continue to go up on norepinephrine, beyond even the protocol, I think is 0.5 mics per kilo per minute, but I've gone all the way up to 1. I've gone beyond that. We'll add epinephrine. I don't think there's much value in combining alpha agonists. And so like norepinephrine plus phenylephrine is not something I would typically do. But sometimes if we think maybe we're missing some occult low output, we'll put on some epinephrine. You have to tailor it to the individual patient in front of you.
Yes, in our practice, he is much less available, and historically we have been employed much higher dosages of norepinephrine in our current practice, and it's a hard way to get down to what is now recommended or studied, and we can read in studies. We're going through that pathway, but we are not much there, and I believe there's going to be plenty of other people that are listening to this podcast that their practice is based mainly on norepinephrine. They are looking for introducing maybe a second vasopressor soon. My last questions, but you can answer twice, 3 times, as many times as you want. In this context, which is the trial you would like to read the most? You can choose one trial that could have been conducted already, published tomorrow. What is the question, your burning question, the things that you miss the most to know for in this setting?
I think the question we've been dancing around this whole conversation is, what is the point at which you escalate your therapy? Mm-hmm. And what is the best way to do that? What agents do you combine versus not? And there's implicit in this conversation, we have this hypothesis that high doses of catecholamines are bad. Mm-hmm. We haven't proven that yet. And so that's, I think, the trial that needs to be done is true multimodal early vasopressor therapy, starting multiple agents at once versus our standard care, and seeing if that really makes a difference on long-term outcomes and short-term organ toxicity.
I believe there's a couple of protocols out there that might...
It's coming.
It's coming pretty soon, so stay tuned, and we're going to read it together. Maybe we'll have the chance to comment it together again in the future. And with this, I thank you very much for your participation. It was a pleasure, and I hope everybody in the audience shared the same opinion with me. Thank you very much.
Thanks for having me.